So this is, in a way, the big picture would dictate that intervention is a very small part of cancer pain management. And so being at the beginning of the day, traditionally you'd have the WHO ladder in mind. You start with the big picture of cancer pain, epidemiology, medical therapy, and this comes at the end of the line. So perhaps some of these interventional talks, and mine in particular, you might think is a bit of a taster, and then you can reflect in the rest of the day about where these things sit in the management spectrum. Because, most of us in the pain world start from another specialty, and I often reflect on the place of these kind of techniques. I mean, I sat in an operating theatre for 15 hours yesterday, and in the down moments I'm dictating my pain clinic notes from the day before about patients' psychosocial situation, how much wine they drink, what their brothers and sisters think of their diagnosis. It's a strange combination of specialties, and we should always reflect on the technical stuff, but most importantly, who you do it on and why you don't do it. And that's the important aspect to take away from this talk, probably rather than the technicalities. Why are they required? But most importantly, and does it work at all? What's the evidence? But who should we be doing them on? And that's probably a question that hasn't been answered by the current literature very well. So it's a very opinion-laden area, the management of pain, any kind of pain. And I suppose the question in the mind of the clinician when you see a patient is how much real pain have they got and how much is psychological. Now, we've all moved on in the pain world from that sort of basic dichotomy and that concept, but in cancer pain, I think it's fair to say that we sometimes wrongly assume there is a lot of pathology and a lot of sort of nerve damage and a lot of real pain, a lot of acute nociceptive pain, but you basically can accept in the average cancer patient that pain, it's logical that pain should be there, and it is common epidemiologically, so it's not just a few patients complaining of it. Most of them will complain of pain when they get towards the terminal phase. So, and it's logical. And it's also logical that that pain would not be that well controlled by opioids. Those people that work in cancer pain know that, but if you work in acute pain, you see that opioids are not the whole answer for treating pain post-operatively either, and you don't get good results with just using an opiate. You have to prepare the patient psychologically. You have to use non-opiate techniques, nerve blocks, etc., in any kind of severe pain state in some patients to get the best results. So just sort of looking at the wider spectrum, the medical management, when it's optimized, you get about 16 to 20% of patients who fail to get adequate pain relief. And interestingly, and this sort of strikes to perhaps the controversies in this area, 16% failed to achieve adequate relief, only 6% required blocks. So there's 10 or 11% where something else happened, I guess, possibly terminal sedation, I would suggest, but I'd have to dig through that paper to try and work it out. I found it difficult. Interventional studies, randomized studies in interventional treatments in cancer pain, and I'm thinking predominantly of intrathecal infusions, but the neuroablative blocks are even more anecdotal and evidence-wise, except for, I think, celiac plexus block, which Dr. Ma is probably going to talk about more than me. So this study, they randomized patients to further medical management in a specialist centre or an implanted intrathecal pump. So not what I'm going to talk about later, which is the percutaneous exteriorized infusions, but an implanted pump, where you're pretty much limited to morphine, clonidine, maybe ziconotide as well. But they still did produce some degree of impact. So they had more patients getting down to a mild pain level and less patients failing to get some pain reduction or side effect reduction. It was a crossover study. It wasn't blinded, so still suffered from some limitations compared to a traditional level 1 RCT, but it's probably the best we've got for those long-term infusions. So there's a suggestion that it helps, but it's not hugely impressive. And if you just make a superficial analysis of the evidence, you might say, oh, it's not that good. Then this review came out a couple of years ago, and sort of generally in the sort of pain management in cancer pain ether over the last 5 years, it's been the view has been that interventional stuff, and especially intrathecal infusions, are not really necessary in most patients. They were overused. We should stop using them. And I can't really say why or when that occurred, but this review is one of the kind of bits of literature that pushed this view. But we had a massive drop-off in referrals for intrathecal infusions over the last 5 to 8 years, I'd say. We were doing more of them before that. And so I've been reading around it more. And yeah, there has been this sort of political thing that they don't really work very well. And of course, the systematic reviews said the evidence isn't very good, which really meant there wasn't any. There was very, very few studies of any quality in the traditional sense. And so that was the state of play. And there's been a recent study just done in Scandinavia where they just went back to baseline and did an observational study on 9 patients. And this was the subject of an editorial by Harold Breivik, who's a sort of very, very elderly and established figure in the pain world. And he said, look, it works. I think this swing away from intrathecal infusions because of a lack of evidence just reflects that, a lack of evidence. So on this chart, each colour is one of 9 patients. And T0 is before the intrathecal therapy was put in. These patients all were with incurable cancer, had an exteriorized intrathecal infusion, so with a CAD pump and high volume infusion, not necessarily high volume, but higher volume than you can do with an implanted pump anyway. And so T1, 2 and 3 are various stages after the therapy's been initiated, and T4 is just before death. So you can see that most of the patients, most of the time, had very good pain relief. Observationally, of course, it was observational, but very good pain relief compared to pre-implant. And bear in mind, most of those patients were in a specialised centre and had had their medical therapy maximised, radiotherapy and chemotherapy optimised, etc. So they did quite well pain relief-wise. And I'm sorry, the slide's a bit shaky, but essentially T1 to 2, so just after the implant, there was a little bit of side effect with motor block and urinary retention and hypotension. And the big issue with these infusions is, and I'm guilty of saying this to patients, and Paul will quote me from last week saying, don't bother with clonidine, I've never seen it work. But I think I'd be guilty of what everyone else has, is perhaps not even exploring the option. So what this team did was they put clonidine in to minimise the local anaesthetic dose, but they still used local anaesthetic, so they had the triple mixture. And you can see that at T3, there's only 1 out of the 9 patients had any weakness or urinary retention. So what I've seen in my patients over the years has probably been me not quite using the right cocktail. So they had very good results and minimal side effects. So if I can say to my patients, probably we'll get this in, your pain relief will be better, and you'll still be able to walk and pass urine, that would get most of them over the line, because that's what puts most of them off. So it's very interesting data. Now, more importantly, who do we do it on? So conventionally, you say patients with severe pain and or unmanageable side effects. And if you go and see most of the referrals we get from the palliative care team here, they all fit those criteria. So there is another issue here, which is, have they really got the right goals and expectations? And sometimes we walk in and say, oh, you're the person who's going to fix me. And I think really, if I had to summarise the issues with interventional stuff over the years, it's been that the patients, the reason for referral to the pain service has to be carefully examined. And in many cases, my gut feeling, and I can't prove it because the patients won't admit it, is that they still want us to cure their cancer for them. They want their life to go back to normal. And that is a big issue. Very often they've refused a palliative care referral and the oncologist to refer them direct to us much earlier in the disease, and that's an even more obvious situation where they really don't want to be referred to palliative care because they're still in active treatment. And so we're just there to fix the pain while they're in active treatment. And that's fine, but when they have more advanced disease and they really just want their life to go back to normal, you're still dealing with a failure of acceptance and needing to discuss goals. And those patients will be disappointed with whatever we do to them. So we can try and talk about the two sort of extremes in terms of responses. So when you get down to it, you have to think about other things like, can we really block this pain anatomically? But probably even more importantly, have they got the resources? Will they turn up on time for the refills? Will they ring you on Christmas Eve saying, I've accidentally cut the tube with a pair of scissors, because which has happened to me, because they wanted to tidy themselves up a bit. They've got to understand and cooperate. So, oh, Dr. Brooker, your patient's dripping CSF on the bed in emergency. What do we do? Okay, I wish I hadn't put that in. So some patients really, really need an intervention, and an intrathecal infusion just isn't suitable because they can't cope with the attendance from refills. The family support's very limited. They don't understand. They'll never understand how to use the device. And for some of those people, an ablative procedure can help because they really can't accept the idea of having a bag. They've got specific situations which will respond to a cordotomy, like unilateral leg pain or unilateral chest pain, or some other situations such as advanced disease in the pelvis. They don't need bladder and bowel function because they've got a stoma or a urinary diversion, and their mobility is poor anyway. You can put intrathecal phenol in. So there are situations where you can do that and get a short to medium term response. But for most of them, we're talking about, can we put an intrathecal infusion in? Because it's reversible. You can put it in. If they don't like it, you can turn it off, and it doesn't damage anything. So there are some considerations particularly about, and also, finally, I suppose, can they stand 2 hours of general anaesthesia? Because that's essentially what we do to put it in. I mean, you can do it under sedation, light anaesthetic, etc. But it can be, there's some patients who just physically can't manage. And then you can either not do it or put just a simple percutaneous catheter in and say, look, you're only going to be alive for a couple of weeks. Or you might not say it, but just apply the technique for very short-term use. So rather than going on too much, it's always good to bring it back to a patient, and we've got one recent patient. This is pretty much someone we're still looking after. So this is a classic example of the good responses. We'll talk about one that didn't go so well. So this patient has metastatic lung cancer, and the pain is coming from sacral metastases with pretty much a fractured sacrum and lots of plexus involvement. But she still has bladder and bowel control. So she'd like to be able to walk and still go to the toilet and manage and not have a catheter. And as it happens, and I hope, she was happy for me to talk about it, by the way, but I hope there's no family members here that anyone would find it intrusive. But she is a registered nurse, and it turns out, when we talked about things, had a morbid fear of having an indwelling urinary catheter. Quite a sort of phobic sort of response to that. So anything that we did that was going to make her incontinent or put her in retention was going to be a problem. So I was a little bit nervous about going ahead with anything, but she was clearly a candidate for an intrathecal infusion. She was on high-dose systemic opiates, perhaps not high-dose by some of the doses you're used to, but she was a very, very, very small Chinese lady, and she was, the sort of person who's not going to tolerate high doses of opiates well, and she was getting nausea and vomiting, constipation. She's insulin dependent, so she was having, her sugars were all over the place, which was making things complicated. But she was very realistic. She said, look, if you can't do anything, you can't do anything, that's fine. And the family were on side about whatever she wanted to do. So we decided to go ahead and just try intrathecal opiates only to start with. This is the X-ray picture during the insertion. So you put a needle into between the vertebrae. Some of you will be very familiar with this, some of you won't. So you can see, so we use a long-term catheter, it's silicone, and there's a guide wire, and you can see the guide wire heading up north towards the head. And then after that, you take the needle out and start tunneling the catheter. This is halfway through the tunneling process. So you can see that we've got a full theatre prep and scrubbed up and so on. It's quite a palaver, takes quite a bit of resource. This is halfway through the tunnelling, so we pull the catheter through and then just have a single stitch in the back, so which is, so it's not a lot of surgery in the spine. But then at the front you have to place a port, which is quite fiddly and technically can go wrong. They can kink off and the port can flip and so on. So there's a certain requirement of expertise in the people doing them to make sure that it works properly. Basically, you can combine a general surgeon with an anaesthetist to put these procedures in quite successfully, but we just do them ourselves. The surgeons, of course, are used to putting ports and Hickman lines in and so on. Radiologists can probably do this stuff as well, but we'll hear about that. And then this looks a bit messy, but yeah, there is a surgical wound to heal up, and the reason I put this messy slide on is to say, it doesn't just go in. The patient has to recover and heal up, and it can get messy, and they can get infections, and the port has to come out, and so on. But most people they heal up fine, and this was just the day after the procedure. And you can see there's an exteriorised, there's a filter underneath that gauze swab, and then there's a catheter, and they have a CAD pump, which a lot of you will have seen. The CAD pumps, by the way, have a PCA function, so often it helps to have a bolus function for the patients to have flexible dosing and keep their dosing low. And also, I think bolus functions improve your placebo component of your response, so that's always a good thing if people feel like they've got control. The outcome so far. So what often happens is people overdo it when they first get the pain relief. So she went from a forearm support frame, dragging her right leg, to walking around the ward with a walking stick, like Superwoman, and then she sort of paid the price a few days later. But she had dramatic functional improvement, basically stopped her opiates, barring a little bit of withdrawal. So I think people do get systemic withdrawal with anxiety, some pain flares, some diarrhea, and so we tend not to take them off their systemic opiates completely, just get them down to a baseline level, usually the level they were at 3 months ago before things escalated. But her bowel function is much improved. She's much better, basically. Only on intrathecal morphine or hydromorphone, I think. I would anticipate that we'll have to add some local and some clonidine as the weeks go on, because she'll get more and more tolerant to the intrathecal opiate, and then the pain will probably progress and we'll need to add those things in. But so far, so good. Now sorry, I think I wrote this late at night. This is another patient, and this man had bladder cancer. He'd had a big operation. He's referred by the surgeon, hasn't been carefully analysed by oncology, by palliative care, just by the surgeon. He's got terrible pain. He shouldn't have terrible pain. Can you please fix it? And we were presented with an anxious man who thought he'd been cured and still had all this pain. So, tricky situation when a few weeks, and we didn't like the look of him. It seemed not a lot of tests had been done. The pain was quite, the pain was quite severe. It responded to opiates. It was progressive, and sure enough, when he had further detailed investigations, he had a recurrence. So at this point, he's losing faith in the system, as people do in that situation. And he was seeking more options for his cancer treatment, didn't want a palliative care referral. He also wanted to carry on life as normal, go to work, etc. And at some point, this is a few years ago, at some point we went ahead with the procedure, full of reservations, but we still did it. Then his disease progressed, didn't respond that well to treatment, and he became immobile and lost continence, and he was never happy, even though his pain control was probably okay. I just think we didn't work him up enough. We should have gone through a process and really got him. I think if I'd assessed him now, I would have been more cagey and said, well, look, we really have to get your cancer diagnosis and treatment sorted out, and then we'll talk about those interventional things. We needed to somehow pick up, and it's tricky, how do you do that? We had needed to somehow pick up all his issues and expectations. And probably what we should have done is said, okay, you've come to us for the first time, this is what we do in non-cancer pain all the time, comes as the first time, you don't get over the threshold until you've had a clinical psychology assessment, a physiotherapist and everything. And I'm sure we would have picked up all those issues if we'd thought about it longer and harder at the beginning. So, in summary, see how we're going. Some cancer pain does need interventions, I believe, to get the best result. But patient selection's tricky, and they need a lot of support ongoing. So, I might leave it there and talk to you later. Thank you.
We've got a minute for questions.
Sure, yeah.
We've got a couple of minutes for questions if anybody would like to ask Charles a question.
What about the pain threshold? Some women have higher pain threshold and some have lower pain threshold. So did you look into ethnicity, how old they were when you were doing all this research?
So there's a question about issues like age and pain threshold, just for the recording. Sorry. Yep.
Well, this is just reporting other people's data, mostly. I think across the pain research literature, these things have been examined, but specifically in reference to interventional treatment, I don't think it has been carefully examined. It's been on larger groups of patients across the pain spectrum, cancer pain spectrum, and there are differences in pain behaviour, you know, what people say to us and how they behave across different ethnicities. And we, of course, we all have our own concept of how you analyse a patient's pain threshold. I mean, a lot of people don't agree with that concept of pain threshold. So I can't really answer that specifically in response to this. No.
Where I work in Victoria, one of the big issues with externalised pumps is patients not being in hospital in the community and the care of those pumps in the community, to the point where probably now we only put implantable devices in frequently. And I'm just wondering, it sounds like perhaps externalised devices are used a little more. I wonder how they manage in a community setting, community nurses and upskilling nurses in that setting.
Yeah, well, that's a big inhibitor. You're right, and you see that this technique, it's extremely regional in terms of frequency of usage, and so it relies on, I guess, key opinion leaders to drive it. Because if you look in Adelaide, it's used frequently, South Australia, because of a couple of people I know there, that there's been a tradition and it's been driven by 2 or 3 people who've consistently remained in the same job for long enough, and then a couple of pain specialists who happen to have very good links with the palliative care guys have just driven it. So if the community nurse says, how do I operate this device, and you have a pain clinic, for example, with a CNC who's prepared to reach out, medical staff who are prepared to support them, the whole system can grow. So we've seen, however you want to describe this, but it's very patchy, so it's not organised, it's not systematic. We don't have a system in place. It's really locally driven, and the variation in use across the country tells you that. So here in Sydney, it's very, very patchy, the exposure to it. But we, on the north side, I guess we have a CNC. We've got an established centre. The community nurses who need authorisation to use. They need training, minimal training, because they do it in other formats, but they need some training in changing the gripper needles, and the family have to support the patient. They have to come and pick the bags up, because it's expensive getting them outsourced to an external manufacturer, the bags. So then you have to have drive from the centre to say to the hospital pharmacy, okay, if there's a problem with funding, we'll pick that cost up, and the hospital administration has to support it. How's that going to happen? The clinicians have to drive it. So it really has to come from us to say this is a good treatment for our patients. And I agree, it's very, very challenging. And if a patient says, I've got no money and no family, it's like, well, you've got no intrathecal infusion, have you? We better do something else.